Hey everybody, I figured with proning being a big topic right now, I thought I would throw a little quick presentation and video together for everybody so that way we can kind of get the science behind it and why it's being used more now with COVID-19 being more widespread than than it was previously, and now proning is kind of being one of the go-to treatments to help with preventing intubation. So let's get started. So what is proning? Proning is just simply placing someone from their back onto their stomach, similar to the technique that they use with infants. But unlike an infant, we're not proning our adult patients to help with the muscle development of the upper half of their body. But just like an infant, you need to supervise them so they don't die. So before you get to the proning, you kind of need to understand what the pulmonary west zones are in a patient who's sitting upright. As you can see, zone 1, you have more ventilation than zone 2 than you do with zone 3. So there's more oxygenation towards the bases of the lungs than you see in the upper two segments. So with most pneumonias traveling down into the lower airways, that's the most common reason why that these patients don't saturate well, is because their airways are blocked with secretions, which creates a shunt, which doesn't allow for oxygen to be picked up in the lower airways where blood flow is the most. So just a little drawing I found online. So the three zones, you have the apex, middle, and the base. In zone 1 you have more ventilation than perfusion, or the VQ rate, V is higher than Q. It's just more alveolus, then you have blood flow. Zone 2, you have the middle where your ventilation equals perfusion, or V equals Q, and then the the ventilation can keep up with the amount of blood flow that's going through there, and then the ventilation is least in the bases of the lungs because you have less alveolus than you have vasculature. So is tummy time really that important? And the answer is yes. So just to kind of make it more simple, so here in the upper right is the drawing where patient is sitting upright. You just see where you have some perfusion versus no perfusion, but then you take someone and you put them on their stomach and you actually cause more perfusion in the anterior and the base of the lungs during proning, which helps them oxygenate better by having a better VQ ratio. So that's a CT of when you have someone in a supine versus a prone position. If you look in the blue in the left, someone who's supine, you just see they have less lung to work with because the heart is pushing towards the posterior, and it causes decreased lung compliance. So when you put someone in a prone position, it actually shifts their heart forward towards the anterior, which allows the lungs to expand better. And as you can see, there's less blue there, which means there's less dead space. So you have better pressures, better tidal volumes, better minute ventilation, and it's just you have more lung protection going on than you would for someone who's supined. And some places I've seen in some of the research I've done, some of them are using the gel pads they use in the OR. I've seen some of them that are using just more pillows. It just depends on what the hospital is doing. At my facility, they're using a lot of pillows, and for the face, they're using the pillow for neurosurgeries for the intubated patients, so that way that the ET tube, it lowers the risk of accidental extubation for these patients. So just as a small disclaimer, make sure you always refer to whatever your hospital's policy is for proning. And I'm just presenting these ideas merely for educational purposes. Or if you don't have a policy and you're just looking for ideas, you're welcome. So before you flip the patient onto their belly, there is no broad strokes to be painting this picture in. Everybody is unique, and all clinical presentations should be considered before you do this. TBIs, having increased intracranial pressures, patients that are pregnant, fresh tracheal surgeries, patients that have facial fractures, stuff like that. I found something from the London Health Sciences Center, and they had a list of a bunch of reasons why contraindication of proning. But before the patient, if the patient is intubated and you need to prone them, you want to make sure they have an NG, OG, or a drop-off tube to maintain nutrition. Obviously, if they're breathing on their own, or they're on BiPAP or a high flow cannula or something of that nature, they can just turn over, go supine or prone, at their convenience, or you can just remind them to, be on their belly for an hour, or whatever the schedule is. But, for patients that are intubated, they need to be fed, and unless there's some sort of contraindication, obviously TPN will be your best method to get them some semblance of nutrition, and unless they are contraindicated, reverse Trendelenburg is the best physician to prevent aspiration of tube feeds. You just don't want them to reflux gastric contents into their airways. That'll be a whole nother set of problems. And, but once you get everything squared up, make sure you remove all the electrodes from their chest, and make sure that they have the additional plastic plumbing extensions, like Foley extensions, rectal tube extensions, chest tubes. We usually do something with the ET tube because of drainage, because usually we put a heated circuit on there, so you kind of want a little something extra on there to drain the secretions out. And before you want to flip them, you also want to make sure you have respiratory available with intubation stuff, just in case there is an accidental intubation. Make sure you have multiple nurses, 4 or 5 if you can, just to see if you for one muscle. And also it wouldn't hurt to have fresh eyes and have them go over and do a mental checklist to make sure you have everything, and if there's anything else that you need. A physician, nurse practitioner, physician assistant, some of them to be there in case you need a reintubation in a hurry, or just to ward off evil spirits. So the patient's going to be flipped, and you always want to make sure you check the hospital's policy for proning. If you're in a hospital bed, make sure you have a lot of pillows on hand to relieve pressure points in the shoulders, arms, feet, thighs, stomach, wherever you feel they may develop a pressure ulcer, and before you do that, you put the pillows over top of them while they're supine to get an idea if you need more or less, or whatever the case may be. And if they're intubated, the facial cushions used during neurosurgery work great to support the face, so that way you run a lesser chance of having a pressure sore from a endotracheal tube. And we use tape. We normally use Hollisters, but for patients that are proning, we take the Hollister off, and then we tape. And then, so everything's straight, you go to flip, and so if you look on YouTube itself, you can find just so many videos of techniques on how to prone the patient. Some people are just putting pillows over top of them wherever they're going to be putting the pillows while they're proned, and then they throw a sheet over them, you roll it tight, you have respiratory manage the airway, or they can hold C-spine, and then you log roll them over to the prone position, and then you kind of iron out the wrinkles from that. Some are just doing a flip like you would use, like you would kind of roll them to change soiled linens with the patient still in the bed. You always want to check to see if there's a policy to do so, or if whoever your attending physician is, they feel most comfortable doing it. You want this to be as less of a dramatic procedure as possible to lessen tension or something. So now we're prone, and then you always want to make sure you have the RT check and reassess the position of the ET tube to see if it hasn't navigated out or it has advanced itself from the flipping. It's not uncommon for the ET tube to kind of withdraw a centimeter or two when they're being proned. If the physician's okay with it, then it's fine. Usually when you flip them back supine, it'll advance itself back to the original position. You'll make sure you put the electrodes on the patient's back to monitor for ECGs, and then you just want to properly position the extremities to reduce the likelihood of getting pressure sores on, let's say, their feet or their elbows or something of that nature. Shoulders are a big one too. So concerns, and I got this from the London Health Sciences Center. You want to reposition the head every couple hours, and then you just want to assess and move devices and tubes to make sure you're not causing pressure ulcers on the skin from, let's say, like I don't know, like a IV line or something of that nature. You don't want the patient laying on any sort of tubing from, let's say, the ventilator or a chest tube or a Foley. You don't want any more of the stickies for the electrodes for the chest. You don't want any EEG leads on the side of the head that goes down, because that'll cause pressure sores. You want to keep the eyes as moist and keep the eyes closed to reduce the risk of corneal abrasions or something. And then you want pressure relief for the knees. The London Hospital is doing the gel pads they use for in the OR underneath the knees, and you want to dorsiflex the feet to keep them at a 90-degree angle, and you don't want the toes to point down, I'm assuming, for foot drop. And then some of them are using, like I said, they're using the gel rolls underneath the lower shins to keep ankles off the bed. Some for women who are well endowed, you want to kind of push the breast to the more lateral to reduce pressure on the breast and the nipples themselves. Try and keep male genitalia as free as possible. Try and keep the pelvis raised, because you can actually get a pressure sore on your penis. Keep the Foley between the legs. You don't want the patient laying on Foley tubing. And you kind of want to keep the shoulders relaxed as much as possible. Move the arms whenever you can. And then if you can put them in a swimmer's crawl if they need to. I've never seen it, but it's possible. And then you want to try and protect against ulnar nerve injuries, reposition the arms and stuff like that. So the ARJO Huntley RotoProne bed is something that we use at my facility. It's a good product, and I went to the class from the representative, and I actually got to be the one they strap into the bed, which I thought was kind of cool. And that's what the patient looks like for the most part when they're supine. We do our patients without a gown on, and I'm sure they probably have a pretty good reason why they have a gown on for this photo, but we do our patients without a gown. That gray track in the center, that's for the Foley and the rectal tube. Obviously this patient's being transported on the RotoProne bed. I've never done that before. And that's what they look like supine. You want to lift those back hatches up to relieve the pressure off the back. And then we have a little piece we stick under the bottom one to keep pressure off the heels, and do what we can. And there's the little rack for the chest tube right there. There's a Foley bag. We have another one we use for the rectal bag as well for the poo tube. And that's pretty close to what a patient's going to look like prone. I just found this photo on Google, but the little face shield right there, there's the ET tube. You're buckled in, strapped in, and that's it. that's identical to what you're going to look like when you're proned. And as you can see, the patient does rock back and forth for postural drainage and reverse Trendelenburg. So from their website, I just kind of copied some of this stuff. So these are the benefits of using it. You can use it for postural drainage. You can rotate it up to 62 degrees on each side. And if you want to set a pause, you're more than welcome to. I think it's up to, I want to say 45 minutes. I don't remember off the top of my head, but I think for some reason that number sticks out. And then the way the padding is set up with the seatbelt buckles is you position it, and it's able to move up and down more anterior, or superior, inferior on the chest, belly, knees, wherever, to make sure that you can offload pressure on parts of the body, so that way you have a lesser chance of getting ulcers. And then you have in the face shield, you put, that's where you can make sure that the ET tube is positioned properly. And then there's the other area for in the top for oral or nasal gastric tubes, drop-off tubes, and then the bottom has for Foley and rectal tubes. So I mean, there's just all sorts of ways you can put tubes so that way the patient can rock back and forth freely. And also, if the patient codes, they can start CPR in as little as 40 seconds once the CPR mode's been initiated. And there's also a bunch of YouTube videos demonstrating how this bed works. I don't work for the company. I just work at a hospital that uses it, so I am fairly familiar with it. It's a good thing, and it's very user friendly. So I like it. I can't say the same for the nurses, but I think it's a neat product. And then I saw this in one of the respiratory care journals. How to properly skin prep these patients to prevent breakdown, so that way you lower the chance of getting pressure ulcers. Our hospital does have a policy on where to put padding to reduce the likelihood of getting pressure ulcers on the knees, shoulders, chest, and stuff. And then here's a video of a patient who was RotoProned, who was COVID positive, and the patient lived and was able to leave the hospital. They were wheeled out in a wheelchair, so it does work. And they're excited, because they get to have some tummy time, and that's all I got for us. So if you have any questions, feel free to email me, mediocrerrt@gmail.com. Hit the subscribe button for more content. If you have any content ideas that you want some clarity on, or you just want education on, I'm more than happy to throw something together, and maybe we can get some more videos out there. So thank you very much.